Good evening, all the viewers, to one of the most popular Med Talk show, that is Dr. K.K. Agrawal Med Talk show. Today's episode is number 501. So I think in the last 2 years, millions of viewers have seen the programs under this particular Med Talk in collaboration with IJCP, Heart Care Foundation of India, Talking Point, and USV. Now, today we are going to discuss about one of the very important topic, and that is related to the gut microbiota, probiotics, and the importance of probiotics in the dysbiotic conditions. Now, when we are learning our medical science at that time, this probiotics topics was not touched to that particular extent, but over a period of time, it is evolved. And whenever any science has to be discussed, you require one of the expert from the field of gastro and hepatology. So I invite Dr. Philip Abraham, who is the gastroenterologist of international repute from Hinduja Hospital, Bombay. He was a former HOD of one of the very important reputed institute, KEM Hospital. I think he's a great clinician, academician, he's a great researcher, and whatever he talks is like whenever there is a required as a third or fourth doctor to get opinion, ultimately the patient comes to Dr. Philip Abraham, and his clinical insights really touch upon each and every, and he guides all of us on this particular aspect. So I think welcome, sir.
Thank you very much, Dr. Abraham, for one of the kindest words that I've heard.
Yeah. I think today we are going to talk about gut microbiota, as I was talking about during our MBBS curriculum. And I am fortunate that you are also one of the teacher, because I was from KEM at that time. So gut microbiota topic was never come in the curriculum. So I think a lot of doctors may not be aware about it. So can you tell the importance of gut microbiota?
If I have to make a beginning, I wouldn't even know where to make a beginning from. Like you said, in the graduate days, we were never even taught about the gut microbiota. Until about 20 years ago, we used to consider that as a dark continent, a place waiting to be explored. And we used to think of that as just bacteria that coexist with us and we are the host. Now we know that there are about 10 times as many microbial genome as there are human cells. So actually, they are the host and we are the parasite, meaning we are just being a host to something that outnumbers us 10 to 1. And now we know that as research goes on, not only in gastroenterology, but in other fields like dementia, for example, or several neurological conditions, that the gut microbiome is the key player in all of this. So our thinking has changed dramatically from ignoring it to now incriminating that in almost every disease.
Yeah, I think one of the very important point you talked about is that the outnumbering of bacteria which are beneficial in human beings. And you are talking about GI diseases, but what is important is that overall health of the body. So which are the different areas you mentioned about neurons, but apart from that, what are the different areas where the gut microbiota has got some role?
So if we start with the gut itself, we know that the microbiome that we build up in the first week of life evolves very little as we progress, and by the end of the first year of life, we've already achieved our adult pattern of microbiome. Now, this is extremely important because we know that later predisposition to disease, later predisposition to lifestyle changes, all depend also on our microbiome. So, starting with how we acquire the microbiome, whether it is vaginal delivery or cesarean delivery, the kind of spectrum of microbiome we get is so different. Administration of antibiotics and also probiotics, now we know in the first week of life how it changes the spectrum altogether. So the formation, the qualitative distribution of our microbiome starts from the first day of life. And as years go on, we realize that the pattern of the microbiome remains the same almost continuously throughout the ages or throughout the years, except that as we reach senility or as we reach past 60, past 70, there are some qualitative changes in the microbiome. Of course, dramatic events like chemotherapy or whole body radiation may also cause significant changes in the microbiome. Otherwise, for practical purposes, there is a consistent pattern right through. So, what diseases we are predisposed to depends to a large extent on our microbiome as well. So, starting with our gut, things like response to infections. We think of single infections, like, for example, Helicobacter or Salmonella infections or Shigella infections. We think of this as an invading microbiome that takes over the microbiome of the gut and causes disease. Now we know that how much predisposed we are to disease, or what role these microbiomes play in our intestine, depends also on our gut microbiome. So the same infecting microbe, like Salmonella, may cause no disease in some individuals and may cause florid typhoid in the other individual, depending on the microbiome. So starting with enteric infections and going from there to obesity, NASH, cirrhosis of liver, SBP, that is spontaneous bacterial peritonitis, so related conditions in the gut itself or in the GI tract, then diabetes, hypercholesterolemia, going even further, dementia or age-related changes, lung. We've always thought of the lung as independent from the gut. But today, even in the context of COVID, we know that our predisposition to COVID to a large extent depends also on how healthy our gut is, because the portal of entry is through the gut in addition to the lung. So, for example, individuals who come to us with COVID have had their portal of entry through the gut. They present with diarrhea and then go on to florid COVID. So there is a crosstalk between the gut and all the organs in the body, predominantly the metabolic functions, the liver, the the respiratory tract, as well as all neurological functions. The gut-brain axis is, apart from the autonomic nervous system, so dependent on our gut microbiome. So it's a critical player in almost any disease that we can think of. Maybe we are stretching the argument too much, but now we are swinging to the other extreme where we're looking at the gut microbiome as a key player for almost all these diseases.
I think two important points during the discussion, which is one of the very important point, is that the crosstalk between gut and all the other organs of the body. I think this is a very, very important new theory you have put up today in the this particular contest. And the second important point you have emphasized is predisposition of diseases related to the gut microbiota component, right? So that is another important point, because in Mumbai city, I think a lot of people eat bhel puri, pani puri, but only one develops diarrhea or few develop diarrhea. So
So
that itself may be one of the point. What do you think about it?
absolutely. I'll give you an example about Japan. Necrotizing enterocolitis was quite common in infants in Japan. And they started giving lactobacillus Shiro- Lactobacillus casei strain Shirota to all the newborns, and dramatically or drastically brought down the incidence of NEC, necrotizing enterocolitis. Secondly, another context that I would like to bring up is patients who are going on antibiotics for everything that we can think of, including for the common cold, or people who are on acid suppression treatment, PPIs. PPI has become, obviously, all over the world, the most commonly co-prescribed drug. What does that do to us? It's going to take away the first line of defense from the gut. So people who have their acid eliminated for no reason on a PPI are much more susceptible. So even preliminary data from our department at KEM at that time, as well as from Calcutta, showed that people who are on PPI and are coming from compromised social strata are much more predisposed to diarrhea. Whereas if you had a healthy microbiome, these pathogens would have just passed through us. So there are so many clinical contexts in which the microbiome is so important. And we are playing with it, antibiotics and PPIs and other immune compromise or immune suppressants. We are playing with the gut microbiome without realizing its importance.
Yeah, I think it is very, very practically relevant. Is that ultimately a drug is a foreign substance. So whenever
Absolutely.
it is required, only at that time you have to give. And one of the point you have raised is that I think all the physicians and doctors they are listening is that the PPI is causing a dysbiosis. I think this is a very important concept which is not. Yeah.
Dysbiosis, apart from in the gut, I
Secondly,
remember in the intensive care in KM, we had done a study where we showed that you can have proximal migration of gut microbiota into the lungs, causing uh, ventilator associated pneumonia, or VAP, like they call it, or causing other infections in the lung in those who are in the ICU, those who have a tracheostomy or a endotracheal tube. You suppress the acid secretion with the PPI, and they are much more susceptible to an infection. So these are points that we put by the wayside because of our focus on antibiotics, but we should realize that prevention is so much more physiologic, so much more important.
And I think the overuse of antibiotics as well as overuse of PPIs in the clinical
Absolutely.
practice. Yeah.
Absolutely.
Now, you also mentioned about COVID because there is a lot of data about probiotics benefit in COVID, and COVID is also altering the. Since the COVID pandemic is still ongoing, can you point out some key point in this?
So unfortunately, we should realize that probiotics are not as strong defenses as antibiotics are. Antibiotics kill. Antibiotics are made tailor-made to bacteria. So you have a known bacterium and you test that bacterium for that antibiotic and you say that yes, this bacterium is sensitive to this and to this antibiotic. So we have focused killing. Probiotics, unfortunately, don't have that one to one relationship. So, we're talking about maintaining a healthy environment so that the body's immune system can function. So, they're not as strong weapons against infection as an antibiotic is, but they're much more physiologic. So, although I'm not recommending any particular probiotic in the present COVID situation, otherwise, sadly, the market would boom on for that reason. Like we're now using zinc and ascorbic acid for everything, vitamin C for prevention where there's no evidence at all. I'm not saying that administering probiotics will prevent COVID, but it definitely will keep our gut healthy and theoretically may even prevent a few cases of COVID infection. Like I said earlier, and like you so rightly emphasized, there is crosstalk between the immune system in the gut and the lungs. So, what has been primed in the gut will also home into the lungs and prevent infection there.
Yeah, I think apart from the infective condition, India has got now it is a hub of diabetes because almost 8 crore diabetes people, 8 crore pre-diabetes people, and the obesity. And even
Yes,
during the COVID time, the obesity is triggered because of the lack of movement
exercise.
as well as overeating.
Yeah.
But that whole process of metabolic syndrome, and there is a lot of data available with the gut microbiota linking the metabolic syndrome. So, what is the evidence talking about this? I think this crosstalk we should discuss because of the India is a predominantly metabolic syndrome country.
So it all began with animal experiments where they found that if you transpose the microbiota from obese rats into lean rats, you could induce obesity in those rats. So it began that way, and there is very strong animal experiment evidence to show that the microbiome plays a great role in obesity and in other metabolic disorders. The entire metabolic syndrome, for that matter, diabetes, hypertension, hypothyroidism, obesity, especially central obesity, dyslipidemia, and to an extent, even thyroid disorders. So, while this has been firmly established in animal experiments, large population based studies as prevention will take many years for it to come. But there is strong critical data to show that the spectrum of the microbiome varies in those who have these diseases versus healthy controls. So, the groundwork has been laid. Intervention has still not been initiated, and the results of those kind of interventions will take years to come. So we don't have that kind of final proof of the pudding, but we have enough background to say that this is likely to work.
Yeah. Yes, sir. Go ahead. Yeah.
No, no, I've come to the that point. More questions. I'm sure there are so many thoughts running through your mind
Yeah,
because you're
another
such a
another
niche.
important another important point is obviously the dysbiosis component. So in general practice, how people can pick up because symptoms of GI disorders are majority a similar kind of thing. So what are the common symptoms do you think that when the person has got dysbiosis?
Yeah, unfortunately, there is no clinical clue to dysbiosis, but we do suspect them in our patients. Of course, I'm not stretching the imagination to talk about treating dysbiosis in patients with obesity or diabetes or dementia or osteoporosis, all of which this dysbiosis has been incriminated in. There's no tool to say that this patient has dysbiosis, but there are clinical contexts in which we can suspect that. And I'll give an example about our patients with small intestinal bacterial overgrowth. We are not putting a catheter into each of them to say that this patient has a different spectrum or that he's got an overgrowth of pathogens in his bacterial spectrum because there is no one bacterium that we can incriminate. Dysbiosis is a general term to say that there is an upset in the microbiome, moving from a healthy to an unhealthy spectrum. So it's not just one microbiome, it's not firmicutes or bacteroidetes that are changing over time. It's the entire spectrum, what we call the microbiome or all the products that go with, like the proteomics and genomics and everything else that you can study. So there is no bedside or clinical clue to say that this patient has dysbiosis. But in a clinical context, for example, somebody who's received an antibiotic, or somebody who's been on a PPI, or somebody who has symptoms of bacterial overgrowth. And I'll give the example, like I said earlier, of small intestinal bacterial overgrowth. We clinically suspect that in patients, for example, who have a lot of gas buildup in their intestine, who have flatulence, particularly those who have foul flatulence. And we know that these are gas producing organisms in the intestine that's causing that. So, and we give a course of one of the common drugs we use is rifaximin because of its safety. We give a course of rifaximin and we see dramatic results. So the proof in this case comes from response to therapy, or what we consider as therapeutic trial, but therapeutic trial in the right context. So these are short-lived situations where we know a short course of probiotic or an antibiotic for 7 days, 10 days, even a month will make a difference to a critical situation at that time. But if we have to talk about suspecting dysbiosis and treating it to prevent a lifestyle disorder, we talk about follow up for years, for which we don't have patients at the bedside. We don't have data also to support it, but a long data to support it, yes, but data not to implement it in the bedside. Those kind of things we don't have.
Yeah, I think one of the very important relevant point you have mentioned is antibiotics inducing dysbiosis. In the
Yes.
last layer, you are practicing for more than 3 decades or 4 decades. Now, what do you think that the antibiotics susceptibility for causing this diarrhea is increased over a period of time, or the people are becoming more risk involved?
Antibiotic misuse has increased, as everybody knows. Every doctor knows that, the public also knows that, and we are one of the antibiotic misuse capitals of the world. Because although we have our various schedules printed on the carton, most antibiotics are available over the counter. And unfortunately, the pharmaceutical industry also keeps generating and churning out more antibiotics, saying strike hard, strike hard. No, if you have a good microbiology setup like we have at the Hinduja Hospital, and if you have a good principle of practice of antibiotic use, you can prevent misuse. But unfortunately, that message has not gone on to the community. It certainly has not gone out to the lay persons, although to a large extent it has hit the family physicians and the practicing consultants. So antibiotic misuse is rampant in India. And we know that almost every antibiotic can induce antibiotic associated diarrhea. More importantly, and we are facing that increasingly even in our institution, the emergence of resistant strains to antibiotics, the emergence of strains that may not respond to our probiotics, and Clostridium difficile. Very important. That's an infection that is now raising its head, ugly head, in the community. Something that even 5 years ago we thought does not exist in India. And personally, I thought it is because of our misuse of metronidazole, a drug that works in Clostridium. But now with antibiotic misuse, Clostridium difficile is becoming much, much more common, not only in the institutions where it was 5 years ago, but in the community as well. So more than 50% of patients whom we detect positive in our laboratory come from the community, not so much from the institution. So getting back to the point, antibiotic misuse changes the spectrum of microbes, brings up resistant organisms, and lays the groundwork for us to also use a probiotic to try and prevent this. Lays the groundwork. We don't have solid data for it.
So I think Dr. Philip Abraham is mentioning to all of us is that the antibiotic scenario is changing and the antibiotics are causing diarrhea and there is increase in the like C. difficile kind of infection, which is also very critical in certain setting. So all these points, I think every doctor has to keep in mind is that the appropriate use of antibiotic, duration, selective use. If it is a viral, one should not use antibiotic. So it's a clinical judgment is very, very critical in this juncture.
Dr.
Now, I
Abhyakar, of
just
course, is
before
young.
this program, yeah,
No, no, I was just talking about the emergence of newer antibiotics. Teicoplanin, for example, was something that we had
yeah.
never heard of earlier. Astronome, for example, is something we hadn't even heard of. And there are new and new antifungals coming up, newer antibiotics coming up, which, if used very carefully, of course, is important, very useful, no doubt. But unfortunately, the pharma industry, for whom the bottom line, of course, is the balance sheet, they will introduce these antibiotics into the community as well. So we've come up with this new antibiotic. So this is available in oral formulation. So the temptation to overuse even the newer antibiotics is quite rampant in India.
Yeah, I think well said. It's very, very important point you have mentioned.
Antibiotic stewardship is something that has not gone into the community as yet. In institutions, yes. Responsible antibiotic prescription.
I think many of the developed countries definitely this policy is followed, and even the antibiotic strict at the which primary or secondary, tertiary level, which selection of antibiotic, and even the antibiotic rotation policies are followed in the hospitals just to reduce
Absolutely.
the
Yeah,
toxicity.
it won't surprise you to know, of course, I'm sure you know about it, that in institutions, major institutions abroad, the decision on which antibiotic to use is not taken by the clinician. He can take it only if it's vetted by the microbiologist. So the microbiologist has the power to say, no, you cannot use this antibiotic. That is stewardship, which we should have in our institutions and also in practice. You cannot allow the antibiotic to be used in the community so freely. I realize that we are going from probiotics to antibiotics. Our discussion has gone away from the main subject.
Absolutely.
Yeah,
Hey, before coming to this program, during the Medline, I've just put a word probiotics, and almost there are 59,000 references. These I'm talking about PubMed, but there are, I think, more than double in the other sites. So that is the evidence we have generated on probiotic. So, what
absolutely.
is your practice of use in probiotics in GI conditions specifically? Where do
Okay,
you
so
recommend or tell the viewers?
yeah. So, like you said, I had done a Google search on this a few years ago, also, just 2 or 3 years ago, and realized that in the 1980s, nobody even talked about probiotic. You'll even recollect that the definition of the introduction of the word probiotics, its definition by the WHO and the CDC, ultimately got formalized just about 2 decades ago. Before that, we didn't even care about probiotics. Yeah. But having said that, and now that we know what probiotics are and that we can use them in prevention as well as in treatment, the situations that I would use them in gastroenterology practice: number one, antibiotic associated diarrheas; number two, self limited colitis or self limited infective diarrheas; number three, recovery from acute self limiting colitis or acute self limiting diarrheas; and yes, as co prescription for Helicobacter pylori. We have evidence, good evidence, to show that the addition of a probiotic for Helicobacter 3 drug or 4 drug regimen reduces the symptom response to the antibiotics. Symptom response, meaning antibiotics we know have their symptom side effects, and that comes down if you use a probiotic. So, for the short term, whether it is 10 days or a month, these are the situations where we commonly use. There's increasing evidence now that we talked about Clostridium that for prevention of Clostridium infection, long-term antibiotic, I'm sorry, probiotic use also can be advocated.
Yeah, I think many of the doctors are aware about diarrhea or antibiotic-induced diarrhea, but I think one important point you have mentioned to all of the viewers is even H. pylori, where two or three antibiotics are used. So
Mm.
that will also be very critical where the provider and all kinds of colitis. But what is the duration normally in these conditions in your
Generally, we
practice
give
for
it for,
probiotic?
now that we're coming to that point, generally I give it for 10 days, although we don't have the basic science evidence to show that 10 days is enough or 10 days is required. Having come to that point, there's something that I need to promote about the probiotics or emphasize about the probiotics. You're probably going to come to that topic later, but we generally use only probiotics that have been shown to be scientifically shown to be effective in situations. So the point to be remembered, because we know that over-the-counter probiotics are used by the lay public left and right, and today if one probiotic is not available, they'll use another one. So what I keep emphasizing to people is today you've used, let's say, amoxiclav, and tomorrow you don't have it in stock, so you change to azithromycin. You don't do that in clinical practice. A home never does that, but they change from probiotic to probiotic depending on availability. That doesn't work. You need to use one strain that has been proved scientifically to be effective in a particular condition. If one probiotic has been proved effective, let's say in infective diarrheas, it doesn't mean that all probiotics will work. So unless there's strong data for a particular strain, I would not use it. And once I use a strain, I will use only that strain. So we're very selective about our use of probiotics with the same stewardship as we would use with antibiotics. Unfortunately for us in India, we don't have the pharmacy shelf keeping a host of probiotics. But in the West, yes, there are shelves and shelves of probiotics. All of them may be effective, but we go by the science. We don't use them just because they're mentioned as 6 billion spores per capsule or whatever. We don't go by that. We need science to it.
Yeah, I think apart from the gastro disorders, I think another is liver disorders. I think so.
Yes.
What are the liver conditions the physician should use probiotics?
Not again as treatment, let me be clear about that. But yes, there is data to show that in NASH, non alcoholic steatohepatitis, or metabolic syndrome related liver diseases, or lifestyle disorders, NASH particularly, it all ultimately boils down to NASH. In all those situations, there is evidence to show that it may prevent NASH to some extent. But as treatment, no, I would not recommend them as yet. In gut conditions, also in cirrhotics, for example, in the earlier years, we used to use what was available as lactobacillus at that time. Of course, it has evolved a lot since then, but we used to use it at one time to prevent spontaneous bacterial peritonitis in patients with cirrhosis with ascites. So there are some situations where we would still use a probiotic as prevention, but not for lifestyle disorders, not yet. Maybe in the next 5 years, we'll have much stronger data for it.
You have got a lot of expertise on GI as well as liver. There is no doubt. But in what are the three, four other conditions where probiotics are commonly used by the other doctors or other specialties?
Of course, they all use it as co-administration with antibiotics, but I would recommend them in the ICU, for example, where a patient is immune compromised with the use of antibiotics. One major component of his defense has been taken away because he's on NG feeds, he's on PPI, he may have an endotracheal tube or a tracheostomy. So the risk of aspiration pneumonia, the risk of proximal migration of pathogens is very high. So one situation where I would strongly recommend the use of that is in the ICU in patients who are otherwise compromised. Prevention of respiratory disorders, the prevention of respiratory infections. I think that's a very good place where we should use a probiotic.
You also mentioned while discussion is about preventive use in certain cases. And this is a therapeutic use when the patient has got some symptoms and dysbiosis, so we are giving it. Is there any role of preventive or in certain conditions?
Prevention in patients, for example, like I give the strong example of Clostridium. In those who have recurrent Clostridium, not just one episode of Clostridium. In the West, that's become a major problem with antibiotic usage. And of course, their immunity is different from ours. We are actually fortunate to have a microbiome that's healthier for various reasons because of the high fiber intake, the vegetarian diet that we have. Our microbiome is generally healthier than in the West. So they have Clostridium more commonly. But there, with recurrent Clostridium infections, yes, we use probiotics, or it is recommended to use probiotics as a preventive step. In our situation, we use it in those who have recurrent SBP, spontaneous bacterial peritonitis. One extreme example of the usage of probiotics is what we call fecal microbiome transplant. Fecal microbiome transplant is ultimately a gross probiotic transplant. We're taking the microbiome of a healthy individual and putting that into a diseased person. So that has been used even in IBD. In ulcerative colitis and Crohn's disease, fecal microbiome transplant in irritable bowel syndrome, there's good data to support that. So that's an extreme example of gross probiotic usage, taking it from a healthy individual's microbiome and transplanting it into a diseased person. So yes, in prevention in IBD and IBS and in Clostridium, and now also in SBP, probiotics have a good role there.
I think the transplant which you mentioned that indicates that how much is the importance of this gut microbiota in the
Absolutely, yes.
in the human
Yes,
health, right? So that is
yes.
a thought process which is coming up. Is that whenever there is a need, you are
Mhm.
changing the microbiota towards positivity. So I think it's a great example you have given in during this particular period of time.
For the general public, I
So I
also
think
want to say,
all the viewers, if you
I'm sorry, just one last point.
go ahead, sir.
For the general public, also, I want to make one message because a lot of people consume probiotics as a health supplement, which is okay, although we don't have strong scientific data to back it. My point to them is only this: don't keep changing the strain. Don't flip from strain to strain. Don't keep changing the probiotic according to availability. If you want to change your microbiome with the use of probiotic, which may be a dream right now, stick to the same strain right through. You cannot change them in between. That's one message that I wanted to carry through.
Yeah, I think very important valid point. The evidence of probiotic is increasing day by day. Just I was scanning to diabetes and probiotic. I have seen that diabetic food infection or urinary tract infection, or even there
Yes.
is some positive role on lipids or glycemic control. It's a minor role. I'm not telling it's a oral anti-diabetic drug, but the supplementation in the shorter time has given some benefits in certain aspects of diabetes also.
Absolutely. Actually, it skipped my mind when you talk about UTI and diabetic autonomic neuropathy and vaginosis, recurrent vaginal infections. That's one place where the gynecologists have found it very effective as prevention.
So I think what a great learning today for all the clinicians across the globe. I think where we have talked about Dr. Philip Abraham has given his clinical pearls, talking about gut microbiota and the crosstalk with the whole health of the body. He has also mentioned about the GI conditions as well as non-GI conditions, liver conditions, where the probiotic is there. And apart from that, he talked about in the last 20 years, the science of probiotic is evolved and it is evolving every day. So I just request Dr. Philip Abraham to talk the last important clinical point to each and every viewer.
So, like I said, as a general health measure for the general public, we don't have strong evidence a healthy diet plays as good a role as probiotics. In determining our gut microbiome from day one, it's very important for mothers to realize that normal delivery changes the gut microbiome, vaginal delivery versus cesarean. Don't use antibiotics if you can avoid it in the first week of life. Do not have a low threshold for use of antibiotics in early in life because all these will have permanent consequences for the gut microbiome. What you grow up with is what remains with you for life. So don't play around with antibiotics. Go the natural way as much as possible. Stay with a vegetarian diet or a high fiber, high vegetarian diet as far as you can. If you want to use a probiotic as a preventive measure, use one that has science to it. Go on Google. Everybody gets their results from Google and look for the science behind a probiotic. Don't go for the cheapest strain available on the market because there's so many steps that go to developing a good probiotic. So, as a lifestyle measure, if you use a probiotic, go by the science behind it and use the same probiotic right through. I also want to send to the medical profession a message saying that as keen as we are on using antibiotics, keep a low threshold for using probiotics as well. But having said that, both as prevention and as treatment, use probiotics in preference to antibiotics wherever you can, where it's not a life threatening situation. But having said that, use the same or the one with the strongest evidence for it. And also, one little caveat that I want to introduce at this level is probiotics in the immune suppressed. Those who are on steroids, those who are on dialysis, those who have uncontrolled diabetics, HIV, those who are on other immune suppressants, there are isolated case reports of probiotic bacteremia or fungemia. So, in those situations, be a little careful about using probiotics. Otherwise, it's generally safe. Just make sure that what you use is also scientifically proved to be effective. That's a message I want to get across.
So thank you very much, Dr. Philip Abraham. I think probiotic will come in as one of the very important element in the prescriptions of
Yeah, no doubt. No
many
doubt.
doctors, and many patients will get a benefit out of it. That is very important. Ultimately, the patient's benefit is very critical. Whether the doctor is using antibiotic or whether the doctor is using probiotic in the various conditions you have elaborated upon. So thank you very much, all the viewers. I think it's a great Med Talk show. That is KK Agrawal Med Talk show, and we have crossed 500 today. It was the episode of 501 in the collaboration with IGCP. And for this episode, we got a great gastroenterologist of international repute. Thank you, Dr. Philip Abraham.
Thank you so much, Dr. Bianca.
Thank
My
you very
privilege.
much to all viewers. It's a USV and IGCP collaboration.